Respiratory problems are the most important problems. Preterm babies can have respiratory distress syndrome or hyaline membrane disease. A preterm baby may develop apnea of prematurity. Apnea means cessation or stoppage of respiration for more than 20 seconds together with cyanosis or decrease in arterial pulse oxygen saturation or bradycardia. It is common in infants less than 34 weeks of gestation. It may be due to central apnea, due to immaturity of respiratory regulatory center in the brainstem, or obstructive apnea due to hypotonia of muscles or physical obstruction of airway by mucus or airway collapse or extrinsic pressure or aspiration. Due to respiratory distress and pneumonia, they are usually put on mechanical ventilation with its complications of air leak. Due to mechanical ventilation, a preterm baby may have pneumothorax, pneumomediastinum, or interstitial emphysema. Sepsis may be the cause of prematurity, so he may be presented with congenital pneumonia, or later he may develop bronchopulmonary dysplasia. On the left side, this is a plain X-ray, posterior view, chest and heart, showing complete white lung. You cannot differentiate between the lung and the heart, and this is grade 4 respiratory distress syndrome. While the X-ray on the right show heterogeneous opacities, cavities and fibrosis, and low volume lung, a case of bronchopulmonary dysplasia. Patients who are put on mechanical ventilation are liable to pneumothorax or collection of air in the pleura. On the left side, there is a right-sided pneumothorax, as you can see in this diagram. And on the right side, this is a plain X-ray showing left-sided pneumothorax. Cardiovascular problems encountered in preterm infants. A preterm infant may be having hypotension or poor perfusion due to hypovolemia and or cardiac dysfunction and or vasodilation due to sepsis. He may also have patent ductus arteriosus. Ductus arteriosus is a duct connecting the pulmonary artery to the aorta during fetal life. It should be closed after birth. In preterms, these ducts fail to close. So they can be present clinically with tachycardia, active hyperdynamic precordium, bounding pulse. A systolic murmur can be heard best on the left upper sternal border, and cardiomegaly and pulmonary congestion on chest X-ray. Preterm babies have difficulty in controlling their body temperature, so they are liable to hypothermia, and this is an important issue. This is due to important heat regulatory center in the hypothalamus. This is also due to high surface area to body weight ratio, little subcutaneous fat, little brown fat, which is the source of heat during its burning, and there is increase in the transepidermal water loss due to immature skin. Preterm infants are at same risk of developing anemia of infancy as term infants, but earlier, between 6 to 12 weeks. In addition, preterm infants have lower body iron stores, more exposed to blood loss through venous sampling due to hospitalization. In addition, they had bleeding tendency in the form of subcutaneous hemorrhage, organ hemorrhage, or DIC. As regards the gastrointestinal problems, they have limited ability to suck and swallow. They have poor gastrointestinal function, poor motility, immature intestinal enzymes, and very small surface area. They are liable to necrotizing enterocolitis, which will be discussed tomorrow, and to spontaneous gastrointestinal isolated perforation. What's necrotizing enterocolitis? It's an acute inflammatory disease with multifactorial and controversial etiology, and it is characterized by coagulative necrosis. This is the main lesion, and on reparative changes, fibrosis and granulation tissue is formed, leading to stricture later on. It is characterized by variable damage to the intestinal tract, ranging from the mucosal injury to full thickness necrosis and perforation. This is a necrotic part of a small intestine, and lesion usually start in the terminal end. Preterm infants are liable to metabolic problems as hypoglycemia or hyperglycemia. Hypoglycemia is due to limited glycogen stores and weak glucose hemostatic mechanism, which may lead also to hyperglycemia. They are liable to hypocalcemia, hypothermia as we said before, and hyperbilirubinemia. Preterm infants are liable to intraventricular hemorrhage from the fragile germinal matrix covering the ventricles, or liable to periventricular leukomalacia, which is ischemia or infarction of the brain parenchyma. Both intraventricular hemorrhage and periventricular leukomalacia is found, or it is related to ischemic injury, even if it is minor or minimal. Preterm babies cannot withstand delivery, so may be liable to perinatal depression, and if jaundice is not treated, they are liable to kernicterus. The retinopathy of prematurity. Retinopathy of prematurity is a disorder of developing retina of very low birth weight preterm infants that potentially lead to blindness. Retinal vascularization is incomplete until completion of 32 weeks of gestation. Thus, for infants born prior to this gestation, there is a risk of abnormal vascularization of the retina. These abnormal vessels are weak, immature, fragile, can leak, leading to scarring of the retina and retinal detention. So it is potentially may lead to blindness. It is related to oxygen toxicity. Regular ophthalmological examination of at-risk infants to identify distribution and severity of vascular changes is important. Renal complications of prematurity. Preterm may be liable to hypo or hypernatremia, hyperkalemia, renal tubular acidosis, renal glucosuria, and edema. There is immaturity of the renal tubules to handle electrolytes. Preterm is liable to infection because he has deficiency in both humoral and cellular immunological response. He has delicate surface and discontinued skin barrier due to tubes, IV lines, indwelling catheters. Clinical state changes rapidly from bacteremia to septicemia in hours or less than hours to death if not treated well. Infection may be congenital infection or perinatal infection or hospital-acquired infection. Preterms have high growth rates, leads to vitamin deficiency, so supplements have to be given. Otherwise, they will enter easily into nutritional deficiency. Iron transfer across the placenta is maximum during the 3rd trimester, so iron should be supplemented early from the 4th week. Calcium, phosphorus, and vitamin D deficiency are very common in preterm babies, so leading to osteopenia of prematurity.